Now let's define what infarction is. So infarction is basically the area of tissue necrosis that is caused by, or tissue necrosis that is caused by an occlusion of the blood supply or arterial supply to that tissue. Meaning that if there is something that is occluding the blood supply to the brain, for example, that is going to lead to what you call a cerebral infarction. Remember, we have got cerebral infarction. We have 8 different types of infarctions, anyways. So the pulmonary infarction, we have cardiac. Is it cardiac? But we have different types of infarctions. So infarction is just tissue death due to an occlusion of the blood vessel that is supplying the same tissue. So you can have maybe an artery that is occluded. Maybe the cerebral artery is occluded. So if the cerebral artery these are arteries that supply the brain now. So now if those arteries are occluded, maybe due to an embolism or due to a thrombus, which is a clot. So this clot was formed in the deep veins of the legs, and then it has embolized, or it has moved, it has dislodged from there where it was formed from. Then it goes into the heart, right side of the heart. From the right side of the heart, it goes into the left. It is pumped to the the internal common carotid artery. That the adequate the aortic arch. Remember, you have those arteries on the aortic arch. So a thrombus can be pumped through those arteries and find itself in the common carotid artery and occlude the common carotid artery, leading to what we call to ischemia to the brain, and the brain will die of necrosis. So that's basically the pathophysiology. So it is a disorder. So now that infarction can be global, or it can be just focal. If we say global, it means that it is affecting main part of the brain or the entire part of the brain. Well, if we say focal, it's just a certain area. So brain oxygen deprivation causes either global. So if there's oxygen that is depleted, or nutrients that are depleted, what happens is that that can lead to global ischemia or just focal ischemia. So global ischemia, it can be ischemia or hypoxemia, because if you're talking about ischemia, it means there's reduced blood supply. But if you talk about hypoxia, meaning that there'll be reduced oxygenation to the brain. So you can have ischemic encephalopathy, meaning that there's reduced blood supply to the brain. Global, meaning that the entire brain is affected. Or you can have hypoxemic or hypoxic encephalopathy, meaning that there's reduced oxygenation to the brain. Or you can have focal ischemia. So focal ischemia is just affecting a certain area of the brain. And that is when we talk about cerebral infarction. So cerebral infarction, we're saying that. So cerebral infarction, we're saying that it's just focal. It's not something that is global. For global, you can have oxygen that is diminished. You can have maybe blood that is not going to the tissue. But for focal, we are saying focal ischemia and necrosis, meaning that there's reduced blood supply. Ischemia. We're talking about ischemia here. So that is what you should do. You should remember. So from there, you can have causes of the same infarction. So this is characterized by refractive necrosis leading to cyst formation. There can be cysts that are formed due to infarction. Now those cysts, remember we are saying those are just like sacs with fluid filled in them. So these are fluid filled sacs. Now those ones are going to be located in the brain. So if they're located in the brain, they'll be compressing the brain structures. They can lead to hydrocephalus. They can cause anything. So what causes the same infarction? You can have thrombosis, most of it caused by atherosclerosis. So now we are going to talk about atherosclerosis very soon under our cardiovascular system. Atherosclerosis, in layman's terms, is thickening of the tunica media of the blood vessel. Now that thickening is characterized by deposition of the atheromatous plaques or the fats in the tunica intima of the blood vessel, leading to the thickening of that blood vessel, and hence leading to stenosis, or reducing the diameter of the blood vessel. If there is that reducing of the diameter of the blood vessel, that leads to reduce blood supply to a certain tissue. So that is what we say. That is what we mean when we say atherosclerosis, getting tired. Embolism. You can have maybe an embolism that is coming from the heart, from the what we call the neurothrombi, from the vegetation of the valves. Anyway, you can have fat embolism, you can have anything that can lead to infarction. Infarction results in a clinical manifestation that depends on the site of vascular obstruction. That's why I said if it is the carotid artery, meaning that it's the entire brain that is going to be affected. If it is just a small artery in the brain, it means it will be just a certain area in the brain that is going to be affected. So it depends upon the site of occlusion or obstruction. So if it is on the carotid bifurcation, it will be very deadly. If it will be inside the brain, it will be at least maybe just some sites of the brain that are going to be affected. But if it is maybe affecting so anyway, the other point is that arterial obstruction in this site causes contralateral paralysis. So you have the carotid bifurcation, the mid to cerebral artery are the most frequent sites of thrombotic occlusion, meaning that these ones you have to remember them. And the mid cerebral artery is the most frequent site of embolic occlusion. This point is a statement and it's a fact, so you have to know it. Carotid bifurcation and mid to cerebral artery are the most frequent sites of thrombotic occlusion. But the middle cerebral artery is the most frequent site of embolic occlusion. So the middle is found everywhere under embolism and thrombosis. For thrombosis, you have carotid bifurcation. That's where that bifurcation occurs of the carotid artery, because the carotid artery is bifurcated or demarcated, or rather divided into two. You've got the internal carotid artery and the external. So now on that bifurcation, that's why the occlusion is common, and also the mid cerebral artery. And then the middle cerebral artery is the one that is most frequent site for embolic occlusion, meaning there's a number that is coming from somewhere else, then it comes there and occludes there. So if everything is, and the pathophysiology is that there's that occlusion that is happening there. So now after that occlusion, you can have diminished blood supply to the site. So if at all if it's on the left side, meaning that you're going to have contralateral paralysis. So contralateral, meaning that it's because of decussations, meaning the other part of the body is going to be affected, because you know that everything is in the brain now. So when infarction is caused by an obstruction of small vessels, it can result in small lesions that are recognizable as lacuna or small pits on healing. Clinical manifestations of lacuna strokes are focal and are most purely sensory or motor. Pure motor lacuna stroke most often results from lesions affecting the internal caps. Pure sensory lacuna cap stroke most often result from lesions affecting the thalamus. So that is straightforward. You don't have to really pay attention to that. Let's just remember there's a cerebral infarction. So this is what we've talked about. Cerebral vascular disease, you can have what we call thrombosis. That is meaning there's a clot, there's a formation of the thrombus or a clot somewhere, specifically caused by atherosclerosis, and I've already explained that. Specifically those areas that are commonly affected. You can have embolism, you can have cardiac myothrombus. The cardiac myothrombi or the valvular vegetations, these are coming from the heart. You can have what you call infective endocarditis. When the valves are affected, what happens is that there'll be some small tissues that are going to be getting detached from the valves, and those tissues can be pumped into the carotid artery and bind on those on the mid cerebral artery, causing embolic occlusion. So it's simple and straightforward. You can have hemorrhage. So hemorrhage is divided into two. You have what you call intracerebral hemorrhage and also the subarachnoid hemorrhage. And we talked about this. So we have intracerebral hemorrhage. This is the hemorrhage, the bleeding that is occurring inside the brain, into the brain structure, within the brain structure. It doesn't matter whether it's in the meninges, as long as it's the brain. That term is broad, intracerebral hemorrhage. So the most cause of intracerebral hemorrhage is hypertension. That is why they treat hypertension. They always treat hypertension as in manage it properly, because they know that it can complicate to this. It can lead to intracerebral hemorrhage, which is very deadly. Because if the blood is coming out, it means that blood can compress on the structures. It can lead to ischemia. It can lead to a lot of things. So the most common cause is hypertension, which is often complicated by minute dilations at small artery bifurcations. So now you have got these small arteries that are just in the what we call the what's that? What do you call that? Circle of Willis. Circle of Willis is that's the brain, the circulation to the brain. So now there are these two small arteries that are there. So now those small arteries they are dilated. So since they're dilated since they're dilated, hypertension is what is leading to that. So hypertension leads to, or in short, that hypertension is caused by the small arteries that are dilated. That leads to hypertension, and that hypertension is one that can cause hemorrhage or bleeding inside the brain. These charcoal bouchard aneurysms may be sites of hemorrhagic rupture. In short, these are called charcoal bouchard aneurysms. So what are aneurysms? Aneurysms is just permanent dilatation of the blood vessel. For example, let me draw something. I've talked too much. Let me draw something so people can get something. So if this is the blood vessel, the normal one, the normal blood vessel. So when you say aneurysm, this is what we mean. So the blood vessel becomes like this. So it bulges. It forms a bulging. It bulges like that. So this bulging, you've seen the diameter has increased. So the dilatation of the blood vessel, permanent dilatation of the blood vessel is called aneurysm. So you can have these aneurysms that you are just born with without knowing you just have them somewhere. They're in your brain. So now due to hypertension, these aneurysms can rupture. When they rupture, they will lead to bleeding. And that is the most what's this? The most common cause of intracerebral hemorrhages, Charcot Bouchard aneurysms, which are rupture. When they rupture, they lead to what to bleeding inside the brain or in the brain's tissue. And then you have subarachnoid hemorrhage. We talked about this. So subarachnoid hemorrhage, remember what I told you, in the subarachnoid space, there's cerebrospinal fluid, meaning that when the patient bleeds or when they have that bleeding, the blood cannot collect. In short, it cannot form a clot because there is what's happening. I'll get back to it later. So what I meant was, so I've talked about the Charcot Bouchard aneurysms. So these Charcot Bouchard aneurysms, I said these are dilated ones, and when these are the sites of hemorrhagic rupture. They rupture due to hypertension. So most often it occurs in the basal ganglia, the thalamus. The other favored sites include the pons, cerebellum, and frontal lobe, meaning that if they start bleeding, that bleeding is going to affect the basal ganglia. Now imagine what is going to happen if the basal ganglia is affected. The thalamus is also affected. These are the things that we need to pay attention to, because it will lead to the letter of clinical features that we've been talking about, seeing about everything that happens in the ganglia, the basal ganglia, will be affected in the thalamus, will be affected. The VPL what will be affected when there's that bleeding, because that bleeding is going to compress on the structures, and it's not going to be a very simple bleeding. It will be, a tensile and an expansile type of bleeding. Anyways, so we go to subarachnoid hemorrhage. So subarachnoid hemorrhage, this one consists of bleeding in the subarachnoid space. So what are the causes? What causes that? So what causes that is very simple and straightforward. What causes that is very simple and straightforward. We talked about this. I just wanted to tell you that in subarachnoid space, the CSF. So now that CSF is, when there's blood, the blood cannot collect. It cannot form a clot when there's CSF. That's what you should remember. It's more like an anticoagulant, just to put it in simple terms. So now, for as long as there is that CSF, the blood cannot collect and clot. That is why it is called subarachnoid hemorrhage instead of subarachnoid hematoma. It's not an hematoma it's not a hematoma because the blood cannot collect. It cannot form a clot there. So subarachnoid hemorrhage consists of bleeding into the subarachnoid space. This is frequently associated with belly aneurysms of the circle of Willis. This is frequently associated with the belly aneurysm of the circle of Willis. Guys, this is very, very important. This is very, very important, guys. So this is frequently associated with what? With belly aneurysm of the circle of Willis. So the belly aneurysms, these are just aneurysms. I've already explained what aneurysms are. It's the permanent dilatation of the blood vessels due to the weakness in the the tunica media, the muscle of the blood vessel. So now they bulge. When they start bulging, those can rupture. And what causes the rupture mostly, I talked about it, is just orgasm, arousal, sexual arousal causes the rupture of the same aneurysm. So they'll give you a scenario. They'll be like, this patient was having sex, and then the what's this? Those aneurysm just got ruptured, and then there'll be that accumulation of the blood in the subarachnoid space, which will lead to increased intracranial pressure and further lead to what's this? The death of the individual. So these are also genetically predisposed, or you'll be born with them because they're more like congenital. You will just will be born with them. Causes include, what are the causes also? You have got what we call the arteriovenous malformations. Trauma, you can have trauma or hemorrhagic diathesis. So for trauma can just complicate belly aneurysms. They are already there. So what happens is that can lead to bleeding there. Or you can have direct trauma, damage in the blood vessels that are specifically responsible for that. Or you can have what we call arteriovenous malformation. These are malformations that I've forgotten how to define them, but it's very important to look up to them, look for them properly. They are very, very important. So you also have the ones that they haven't put there. There's what we call cerebral amyloid angiopathy. So cerebral amyloid angiopathy is the second most common etiology. Let me just write that. The most common etiology of cerebral hemorrhage. They haven't put there. Cerebral, because I saw a certain MCQ on the cerebral amyloid angiopathy. Amyloid angiopathy. Angiopathy, aka CAA. This thing has been coming. So this is apart from hypertension, because we said that hypertension is the first common cause of intracerebral hemorrhage. The second one is cerebral amyloid angiopathy. So what happens in cerebral amyloid angiopathy? What happens is that there are these tumor proteins that are called amyloidogenic peptides. These proteins are deposited in the blood vessels, in the blood vessel walls. So when they're deposited in the blood vessels, that leads to leaking or weaknesses or weakening of the blood vessel walls, and that can lead to us to rupture of the same blood vessels and lead to bleeding. Yeah. So that's what I wanted to mention there on that. And then subarachnoid hemorrhage. The most common cause of subarachnoid hemorrhage is belly aneurysm. So belly aneurysm is the most common cause of subarachnoid hemorrhage. So this belly aneurysm, they rupture. When they rupture, that leads to cerebral subarachnoid hemorrhage. So there can be also malformations like arteriovenous malformation, hypertensive, intracerebral hemorrhage. You can have also hypertension causing belly aneurysm. You can have tumors. You can have hematological disturbances. Maybe there is reduced platelets that can lead to hemorrhage as well in the subarachnoid space. So what are the clinical features of the subarachnoid hemorrhage? So rupture risk increases with lesion size. Whenever in short, as the lesion increases or the size of the aneurysm increases, there is an increased risk of rupture. So rupture often results in, because after rupturing, you remember there will be that bleeding, and that bleeding is going to cause what? Increase intracranial pressure. So when the intracranial pressure has been increased, what happens is you're going to be we are going to have increase in issues. You're going to have headaches. You're going to have nausea. You can have vomiting. You can have different types of symptoms, visual disturbances, because the intracranial pressure has been increased. So now, symptoms. So straining at defecation or sexual orgasm. These are the most common causes of in short, they're the ones that exacerbates the rupture of belly aneurysms and hence lead to what? To subarachnoid hemorrhage. So the patient is going to be having sex or maybe they'll be in the toilet defecating. When they're defecating, there'll be that increased intracranial pressure due to, these are maneuvers that happen. So that due to those maneuvers, that can lead to an increased intracranial pressure and rupture of the very aneurysms, which are called the perianeurysms. When they rupture, that leads to an increased intracranial pressure, causing headache, and that headache is described as excruciating headache and rapid loss of consciousness. They will lose consciousness per minute part, just right there. So between 25% and 50% die within the first rupture. Whenever it's just rupture, they will die. And then the patient will be like, the patient will explain that pain as the pain that they have never had before. Because we're saying the 50% to 40 to 50% patient will die when they have a subarachnoid hemorrhage. What is the take home on the subarachnoid hemorrhage? Just remember that so it's caused by rupture of perianeurysms. These aneurysms, you'll be born with them. They are congenital. What is aneurysm? Dilation of the blood vessel. Abnormal permanent dilation of the blood vessel due to the weakening of the muscle of the blood vessel. So now those they rupture during arousal, sexual arousal, and also defecation, straining during defecation. When they rupture, the patient will die. Boom, they will die like that. That is called subarachnoid hemorrhage. What are the clinical features? Headache. Then they'll be the type of headache is explained as excruciating, and the patient will be like, "No, I've never had this kind of headache before. It's my first time having this kind of headache." And then you diagnose the patient to have what's this of subarachnoid hemorrhage. So that's why you remember. And also remember that this can be caused by trauma, maybe accident, or you can have the congenital malformations like arteriovenous malformations causing that. So it's a lot of things to remember there. Don't forget what we've talked about. Even the cerebral amyloid angiopathy can cause subarachnoid hemorrhage. How can it cause that? We've talked about it. It deposits in some amyloidogenic proteins or peptides, depositing them in the blood vessels, making them weak. And when they are weak there, they are easily ruptured, or they are predisposed to rupture. That's what you need to remember there. So what are the arteriovenous malformation? Because they have just mentioned them somewhere. They haven't explained them in the... So what are the arteriovenous malformation? So arteriovenous malformation are just abnormal, tortuous, and misshapen vessels, shunting arterial blood directly into the venous circulation. Remember, the normal circulation is supposed to be arteries. After the arteries, you have capillaries first. After capillaries, that's when you're supposed to have veins. But if you have now just direct from arteries going to veins, that is called arteriovenous malformation. I hope that is making sense. So the blood is just shunned directly from arteries to the veins. So the middle cerebral artery territory is the most commonly involved, and the males are mostly affected than the female. So this is mostly, or it mostly manifests between the ages of 10 and 30 years as a seizure disorder. So the patient will be seizuring, they'll be having the what's this? They'll be convulsing, they'll be fitting. So because of the same arteriovenous malformation, they'll be bleeding in the subarachnoid space due to the arteriovenous malformation, guys. Very, very important. So you can have what you call the subarachnoid hemorrhage. So subarachnoid hemorrhage consists of bleeding into, oh, we've talked about that anyways. So don't forget subarachnoid hemorrhage. It has to do with what the sexual arousal, sexual orgasm, and the defecation that we talked about, straining during defecation, etc., even the arteriovenous malformation. Don't forget that. You can have what you call transient ischemic attacks. So these brief episodes of impaired neurological function are caused by temporary disturbance of cerebral circulation. So now imagine if there is reduced blood supply to the brain. What do you think will happen? What do you think will happen to the brain? So you are going to have ischemia. The brain needs good supply every time. So now, for as long as there will be that reduced blood supply, you can have what you call a transient ischemic attacks, and that is going to these are not associated with what permanent damage, but associated with precursors to more serious occlusion events. Meaning that if you occlude them today, they'll be okay for a while, and then after tomorrow, you are more like increasing the density or the property or the tendency of the propensity of what's this of developing more serious occlusive events than the previous ones. So this is caused by temporal disturbance of blood circulation to the brain. What else are we supposed to know? Let's do the so that we start with infections when we meet on Tuesday, sorry. So head injuries. You can have also what we call the head injuries. So let's not forget the subarachnoid hemorrhage. So now right now, let's talk about head injuries. So that next time when we meet, we do infections. After doing infections, we'll do a tumors. It means that we are done with what's this? Even Brown disease. We still have a lot, but we are finishing this next week. Within next week, we're going to finish everything and make sure that we go through the questions within this week. Sorry. And after that, we can just discuss. We can do physiology of the endocrine system, because it's a lot. Anyways, we have a lot of things, but still we need to make sure that we just focus on the things that are relevant. We can't know everything, but we have to make sure that we tackle most of the things that are necessary, the ones that are important, just basically the things that we're supposed to know, and the ones that are common in our setup, in our clinical setup. So yeah, so we've talked about a lot of conditions. Anyways, let's go to head injuries. So what are head injuries? What are the diseases that fall under the head injuries? So these are simple and straightforward. They are very simple and straightforward. So trauma, you can have trauma. It's a lot of things, anyways. But I'll make sure that I summarize it as much as I can. So we've talked about cerebral edema. We talked about vasogenic types of cerebral edema, vasogenic and cytotoxic. We talked about hydrocephalus. We talked about herniation. We talked about cerebral pathology of the central nervous system. We talked about reactions of neurons to injury. Well, we talked about the axonal reaction, neuronal inclusion, reactions to astrocyte. We talked about gliosis, and we gave an example of gliosis as amyloid, whatever. Amyloid, forgotten that, amyotrophic lateral sclerosis, something like that. We talked about that. So we're moving direct. We talked about increasing intracranial pressure, which can lead to hernia. We've talked about malformation and development, neurotube defects. Talked about oroplencephaly. We talked about agenesis of corpus callosum. Talked about down walker malformation. We've talked about the aortic diary malformation, type 1 and type 2. We've talked about sphingomyelia, hydromelia. So now let's talk about brain injury. In fact, we talked about cerebral palsy, which is perinatal brain injury, the injury to the fetus while it is still in the mother's womb. That is called perinatal brain injury. We talked about it. We talked about how it is characterized or classified, how the patient will present. So now let's talk about injuries. So the head injuries can result from penetrating wounds or non-penetrating wounds. So this is the question that we asked on the word this year. So the first thing is that what are the causes of head injuries? So head injuries can result from penetrating wounds. For example, what's this? The bullets. So they shoot you in your head. They shoot you in your head. That is called, for as long as it's penetrating, that is called penetrating wounds or injury. If it is not penetrating, it's called non-penetrating injuries. So they'll ask you when you go on the word next year, how do you classify head injuries? So head injuries are classified, one, whether they are penetrating or they are non-penetrating injury. So because the injury, the injurious agent, for example, the bullet is penetrating through your skull, it enters the brain, whatever, in the brain tissue, it can predispose you to infection because it has penetrated, meaning infections can go there and eat up the brain's parenchyma and lead to infections. Anyway, I'm just talking about the same things. So what I want you to understand is that when there is that penetrating injury, there is predisposition to infections because infections will just move and go there direct. That's what you're supposed to know. And then other include non-penetrating injury. So these for non-penetrating injury, these ones are further classified into two. You have what we call the coup injury and the counter coup injury. Let me draw something so that people can see what I am talking about. So, for example, this is the head that is there. So if, for example, you have an injury here, for example, you are moving, you are going this side in this direction, and then there's a car that is coming in front of you. There's a car. We assume that this is our car. You know, to put these are the tires of the tires of the car. So now that car is traveling in front of you, is coming in this direction. So what happens is it hits your head here. This is our head. So it hits your head there. This is your H, the head. Like that. So now it hits your head like that. So the injury that happens at the site of, so this is the site of injury. This is the site of injury. So the brain injury at the site of impact is referred to as coup. That is called coup. If the injury is just there and the brain has been injured inside there. So okay, let's assume that this is our skull, not the head. Sorry. So let's assume this is our skull, not the head. Let's assume that it is our skull, the skull. So if this is our skull, so so if this is our skull and then the car is moving in front of you, it hits your head there, just right there. So it's going to have impact there. Remember, the brain is soft, so it can even shake. It can shake while it's inside there. It will shake like this. It will shake in this direction. So you can have what you call acceleration or deceleration. In this case, since the vehicle has hit you on that side, what happens is that the brain that is inside here, it will move on the posterior aspect. In short, it will just move slightly on the posterior aspect. So that is called acceleration. It's moving in the same direction as the force. And then if it hits you on this side, it was moving this side, and then maybe you hit yourself because you hit yourself in there. But if it was moving, how can I explain this? So there's deceleration and acceleration. In short, look up for those. But that is not important at your level. I just wanted you to know that there's what you call acceleration and deceleration or de-acceleration. So now for counter coup, so for coup, we are saying the injury is going to be just there where the impact is, the site of impact is. But for counter coup, the effect is going to be on the other side. Let's use a different color. So for counter coup, the effect is going to be on the opposite side. Here. Remember, somebody has punched you here. They punch you here. You know, they punch you there, and then you feel the impact on the opposite side. That is called counter coup injury. And then you have what we call contusions. So contusions are something that is different. It's something to do with what we call the brusions or bruising. They'll hit you, they'll hammer you, they'll punch you. And then what happens is that you're going to have discoloration, yellow, bluish discoloration of your face, maybe. So that is characterized by both counter coup and coup injury. So when we talk about contusions, we mainly talk about the blood vessels that have been damaged in your brain due to assist, due to damage the blood vessels, and the patient presents with bruising. That is under counter coup. The guys, this is important for your surgery next year on the ward. They'll ask you. So just remember that. So you have the two types, communicating and non-communicating, whatever. So how about the epidural hematoma? We talked about an epidural hematoma. So epidural hematoma is it's the breeding in the epidural space. So epidural space is the space that is between the pericranium and the meninges, the brain meninges, yes. So the brain meninges, remember the mnemonic we said is DAP. You have the dura, you have the arachnoid, and then you've got the pia mater. So between the dura mater and the pericranium, because the pericranium there is starting from the scalp. Let me just draw, because this is going to be my last. Is going to be my last explanation. So you have the scalp, Then you have the tap. So these are mnemonic keys for your layers of the verses of the scalp. You've got the skin. After the skin, you have the connective tissue. Connective tissue. Let's just write it as sitting. From there, I've got the aponeurosis, which is known as aponeurosis, which is known as Garia aponeurosis. Garia aponeurosis. And then L for loose connective tissue. Then PIP for percranium, which is the bone that covers the meninges, percranium, cranium. Then you have the DAP. So for the DAP is the mnemonic for the meninges. You have, starting from the superficial most, you have the dura mater, and then you have the A for arachnoid matter, Then you have the other P for pia mater. So now what we are saying, what I was defining is what is the epidural hematoma. So the epidural hematoma is the collection of blood that happens between the dural space, the dura mater. So remember, this is how they are, starting from the superficial most, the skin, connective tissue aponeurosis, which is the carrier aponeurosis, loose connective tissue pericardium, and the dura. So between the pericardium and the dura here, between the pericardium and the dura there, you have if there's a collection of that blood, let's use a red color. So the reaction, everything has changed. What? Ooh. Okay. So you can have collection of blood there. You can have collection of blood here. So between the dura mater and the pericardium, that is called, this space is called the epidural space. Epidural, because it's before the dura. It's called epidural space. So when there's collection of blood in there, it's called the epidural hematoma. Because there is no CSF there, the blood does not collect. It doesn't form the core, the oasis. Then doesn't form because there is no CSF, it does form the hematoma. But if there's CSF, that does not happen. So most often we think. So now this is most often with damage to the what we call the meningeal artery. So when the meningeal artery is damaged, is the collection of blood will be between the dura mater and the pericardium mater, and it will collect to form the hematoma, which is called the epidural hematoma. This one is mostly associated with the damage or laceration of the branches or the meningeal artery, guys. This question is mostly asked. This question is what is mostly asked. And then the clinical presentation is direct. What happens is that this patient is going to be hit by a car or by anything, maybe by any injury. And then what happens is that when they hit them, they will just lose conscious for a short period of time. And then after losing conscious for a short period of time, what happens is that they will even start walking. Then they will start even walking, they'll walk some, maybe for 17 minutes, they'll be like, ah. In fact, before 17 minutes, when they hit them like that, they will lose conscious for maybe for 2 minutes, and then they'll stand. They'll be like, eh, that car hit me, it had to hit me a lot. Then they'll stand and start moving. So when they start moving, when as they are going, remember the blood there is that bleeding that is happening in their brain. That's when they will have a lot of symptoms. They will have a lot of rapid deterioration symptoms that will show that indeed there is damage to the brain. Means they were just very fine previously. They were just very fine after eating them. Yeah. Okay. So let's remember that property is called lucid interval. So lucid interval meaning the patient is going to be okay. It's going to be hit first. They will have injury first in the first minutes, and then they will just stand. This is the patient that was just down. He fell because he was hit, and then after 2 minutes, he'll stand and he'll be like, "Hey, that cat hit me," and then they'll start walking. They'll start walking after maybe 17 minutes. Again, they will fall. When they fall, it means that the brain has deteriorated. Now there's a lot of symptoms, a lot of things that are going on, that are happening now. That's what it means when they say lucid interval. Because there's that compression of the cerebrum, the brain, due to the blood, due to that bleeding that is happening, and there's that collection of blood that is going to collect to compress on the brain structures, leading to a lot of different modalities. So guys, they'll ask you this question again. They'll ask you. So for you to understand it, to get familiar with the questions that they ask you on the epithelial hematoma, go to the same book that I shared with you guys. Yeah, the one that is having more questions. So epithelial hematoma is amenable to emergency surgical intervention because bleeding into a brain substance itself does not occur. So it's amenable to emergency surgical intervention. They have to do it frequently. So that bleeding doesn't occur, but it occurs due to epithelial hematoma. It's asked before the brain. Subdural hematoma. This is called this is the subdural hematoma. So the subdural hematoma, the cause is venous bleeding. So this one is venous. The other one is also arterial bleeding, but this one is venous bleeding. Specifically, the bleeding in veins joining the cerebellum, venous sinuses within the dura. So this is common due to damage of the bleeding veins. The other one is damage to the middle meningeal arteries. Guys, these are common in ask. So the subdural hematoma is the hematoma that is between the subdural space, the dural space, and the arachnoid space. Sorry, the dural matter and the arachnoid matter. Between the two, of course, what they call the subdural space. So damage to the bleeding veins, you can have what you call the subdural hematoma. And this is the figure, or rather the structure of the subdural hematoma. This is the one that you're able to see there. Damage to the bleeding veins. What are the clinical features of the subdural hematoma? So this one, it occurs hours to days or even weeks after head injury. This one, it takes time. It is not like the other one. The other one we said it happens in a short period of time. The patient will fall maybe for 2 minutes, then they will stand, they'll be like, that card hit me. Or maybe I feel so bad that or maybe somebody that hit me, that guy hit me a lot. And then they'll be like, that guy hit me a lot. And then they'll start moving. When they start moving, maybe after 10 minutes or 10 minutes, and then they'll just fall. It means that a lot of things have happened in the brain. They can even die. So you have to treat them as fast as you can to prevent further damage to the brain. So this one, they're saying it's hours to days, even weeks after that. So they're saying the volume of hematoma gradually increases as a result of osmotic imbibing of water, resulting in slowly enlarging tumor-like mass. In short, they're saying that because there's that hematoma that is there is complete accumulation of fluid or increased accumulation of blood. There is also fluid that is coming at that area. When that fluid that comes there, what happens that leads to more like a force, an osmotic force that is putting water, imbibing water, and then it grows and becomes like a tumor-like mass. So that is what we have. That is what we're supposed to know on those two conditions. Again, the other thing that you need to know is when you go on the word, they'll ask you. So under epidural hematoma, there's what you call how do you diagnose the patient, or how do you invest the patient who has come with an epidural hematoma? So you use what you call the CT scan, computerized tomography. So when you use the computerized tomography, what are you able to see in the epidural hematoma? This is going to be our last part of our today's discussion. So for epidural hematoma, you will see what you call the crescent shaped or moon-like shaped. Is it moon-like shaped? No, crescent shaped. Lens shaped, not moon. It's supposed to be lens shaped. Lens shaped. You'll see something that is lens shaped on the CT scan, and that is going to give you a hint of what is happening. Lens shaped, or they call it convex lens shaped. Convex. The other one is concave, convex. So just check this from your Google. Convex lens. That's how it looks like. And then if you talk about that's how it looks like. And then if you talk about it, the subdural hematoma is not convex, but it is instead what? It's concave. Sometimes they even call it by a banana shape. It's orange. When you cut the orange into two pieces, so you cut the orange. Let me just draw. The first one is more like a banana shape. So just try to check. Look for them up. Look them up and check properly. Otherwise, they're very important. Check them. The convex lens is for the epidural. What you see on the CT scan is you see the banana shaped, like a banana. So I don't know how to break a banana, but it's supposed to be a banana shaped. And then you have to see, like, you get the orange, then you cut it into two halves. The first half looks like an orange, half of the orange that has been cut. for this one, or concave. Guys, this is important. So we end here for today, so that on Tuesday when we meet, we just continue with the infections. I think infections are also important because they ask a lot of questions there. After infections, we'll go where? Prion disease, after prion disease, myelinative disease, degenerative disease. There are a lot of things that we need to know, guys. So we have maybe 2 times. We have to meet for 2 times for us to finish everything. Even the tumors. Tumors are not common in Earth, but you have to know them. Yeah, so you have to, at least we meet for 2 times. It means that we'll be done with everything. So that we do the physiology of the endocrine physiology. So thanks so much, guys. Hopefully you watch these videos and enjoy them. So I'll post them on Telegram and also my YouTube. So guys will help me sharing the videos to your friends in your group for advertisement purposes, and to everybody that would like to join us, our tuitions, or those that would like to join our tuitions. You guys are missing a lot. It's very cheap and very affordable, and I always give data. The data that is important, the one that is just specific. I don't beat around the bush, just hammer the nail on its head. So I'll just give you the most important things, the way they can ask questions, and also give you the free questions, free data. Yeah, it is as simple as that. So if you want to join our tuition center, kindly contact me on the following lines. My Airtel 0977 402934. 0977 402934. My MTN is 0763 05 4381. Thanks so very much for attention, guys, and enjoy your studies. Thank you.